So yeah, thanks for me to be able to present the subject of de novo genetic disorders. It's a challenging area. What I'm actually going to show you are my views. So not necessarily UCB Pharma overall's views, but certainly my views. So when it comes to the genetics of these disorders, so I'll put it in slideshow. So when it comes to the genetics, we have over the years looked a lot at inherited diseases and got a picture for genetics diseases from inherited diseases. But in the years, de novo disorders were actually most of the time untouched. But things have changed. So with sequencing technology, the new technologies such as whole exome sequencing, whole genome sequencing, many new de novo mutations have been detected. And we've found patients with a variety of diseases with de novo mutations. So it's becoming more and more relevant. And in terms of what we're finding with de novo mutations is that when you look at the rare genetic syndromes, they're actually often caused by mutations in one or two genes. So not many genes, but one or two genes. And that when we look at the pathogenic de novo mutations, the vast majority are involved in dominant genetic disorders. Also, when we think about de novo mutations, they often actually come through gametogenesis and post-zygotically. So, egg sperm cells that have the mutation, or just after the two coming together, the mutation occurring then. And when it comes to a lot of these, actually surprisingly, a lot of them have paternal origin. And the mutation risk increases with advanced paternal age, which is becoming more and more relevant in modern society as parents conceive later, and certainly also the fathers conceive later. I'm actually working in neurodevelopmental disorders, and what you see is that like the major cause of the severe early onset genetic disorders with neurodevelopment disorders actually have these de novo mutations, and that the phenotype is actually rarely inherited. So it's serious, and therefore it's less likely that the carrier produces offspring. So it's very often like a pure de novo, not carrying over in becoming more like a classic Mendelian genetic disorder. Research has shown that mutations are occurring because of errors in DNA replication, but especially like a lack of or faults in the repair after the DNA replication. And also, like, there are DNA lesions occurring spontaneously due to mutagens, including endogenous ones. And again, it's the lack of repair. And Friedman is going to talk about ROS, but it's actually been shown that endogenous ROS is one of the culprits in creating that damage in DNA. And it's been shown actually that the lack of or the suboptimal repair of damage actually is getting worse with age. Also, ROS seems to be increased with air pollution, and perhaps quite interesting more recently, that with global warming, ozone is produced, which also in our bodies produces ROS as well. So it could very well be that de novo mutations, the incidence of de novo mutations, could be increasing. We don't know that, but it could be. These are lists of the disorders that are monogenic with a de novo mutation. So you'll see a big list of neurodevelopmental disorders, and then there is a list of congenital malformation syndromes. But this is not a comprehensive list. These are just examples. These are the things that I could quickly find. So you'll see that there's actually a long list, and altogether they do account for a particular prevalence in the newborn population. So, as I said, many of the severe and early onset neurodevelopmental disorders are caused by Novo mutations. That combined, if you take all of the neurodevelopmental disorders, they affect about 2 to 5% of children. So quite a large number. And of course, out of that 2.5%, 2 to 5%, you'll have some of the Novo mutations. These mutations often result in early mortality, and they are often monogenic, with a penetrance very close to 100%. And that means because the penetrance is 100%, if you have a patient, a newborn, a baby that has the signs of a disease, and then they do the genetic testing and find the mutation, it's highly likely that that patient is a good target for gene therapy. And that for a company like UCB, that makes it, the Novo mutations, a very, very interesting target for gene therapies. The challenges of de novo monogenic neurodevelopmental disorders are actually also what Julie mentioned, is poor recognition by the healthcare professionals. So there's a huge delay in diagnosis. There's a lack of genetic testing, and there's often a confusion of what's shown phenotypically. What is this? And often confused with other syndromes. So an example is with Coffin-Siris syndrome, or called CSS abbreviated, which is a de novo monogenic disorder present from birth. And a survey was done with specialists, so really high specialists, so clinical geneticists, a pediatric neurologist, and they were asked specifically about CSS, and they had to present their patients. And what was found is that only 57% of these patients had a genetic test done. So it's a small number. And then also for those that didn't yet have a genetic test done, the age of these patients was in the range of half a year to 51 years with a median of 9. So imagine this disease is present at birth. Usually the first signs, symptoms are present already within weeks, months, and yet the median age of diagnosis was 9, so huge delay. And that actually, for those that had not received a genetic test, 60% of the patients were given another ID syndrome. And so they were not given the idea of Coffin-Siris syndrome, but another syndrome. So again, showing the confusion with other syndromes. So very poor recognition by healthcare professionals, even the specialists. The other challenge is that when you think about the phenotype of these diseases, the mutation it's not always the same. So take, for instance, Dravet syndrome. So although a lot of patients with Dravet syndrome have a mutation that impacts the sodium channel called alpha-1 subunit, the gene is called SCN1A. Most of the patients have that particular mutation, but not all. So you'll have Dravet syndrome-like phenotypes that carry different mutations. So there's 3 mentioned here. So it's not a given that there's a one-to-one relationship between the phenotype and the gene impacted. And yet another challenge is that one gene mutation can actually show different phenotypic expressions. So again, if we take the mutated gene SCN1A, if we look at that particular gene impacted, then we can see different types of phenotypic expressions. So ranging from mild febrile seizures all the way to Dravet syndrome. So not always clear. Identifying patients early is absolutely critical. I think yesterday we talked about that many times. It's critical because most of the de novo genetic disorders are present at birth and they impact development. So the neuronal system, but other like bone system as well. So the earlier you intervene and treat patients, the less likely they are that they have lasting damage. So it's great to intervene early, but then you need to identify them early. The current situation of time to diagnosis, as mentioned with one publication, it was quite clear that it takes a long time, but actually there's not that much published. And most what's published is actually at the clinic level, at the specialty clinic level. So here you see 2 studies done at specialty clinics and 1 in the general population. The ones at the specialty clinics probably give a underestimation of the, if you take the true population with the disease, including ones not even seen at the specialty clinic yet, then you probably get a different number. So it's likely to be a underestimation of the problem at the specialty clinic. So in a study for Dravet syndrome, the mean or median age diagnosis is 1.6, for Rett syndrome 2.7. But if you look at a study done in the general population in Denmark for another rare disease, the Novo disorder, it was 20.6 years, remarkably long before the patients were diagnosed. So what can we do to help with early diagnosis? So I think that early screening is important. And what would one need for early screening? So one thing is about how do you even start early screening? Do you start by looking at the phenotype, or do you start looking at the genotype? So genotype meaning, do we take all babies and genotype them and then find the disease? Or do we look for signs, symptoms, like problems, for instance, parents noticing it, and then for those candidates where there could be a problem, then genotype them? And what I'm saying here is that it's probably more efficient to start with the phenotype, because to do genotyping for for every child born would be cost prohibitive. But of course, such a early screening program, you would need a tool that has high sensitivity and specificity. The latter is quite important because, of course, as Julie also mentioned, is the disease often is heterogeneous in its expression. So the differential diagnosis is not easy. So that, whatever is done, it needs to have a very strong capability in doing the differential diagnosis. Then the third point of, what would be the best way to start creating an early screening tool, I propose that the best is actually ones that can be used by the patient, or so the person with the disease, or in case of babies, their parents. Why? Because it's in their interest. They see the problem, and they are therefore more likely to be using such a tool. Whereas a primary care doctor, when it comes to a rare disease, it's highly unlikely that if there's a 1 in a million chance of it being a particular rare disease, that doctor will use that screening tool.
Join the meeting.
Good. So where can a screening tool be used? So if you take the patient journey all the way, the baby is born with the mutation. Then there's the first noticeable signs and symptoms. Then the parents noticing that, saying, hey, is this correct? What's going on here? Parents getting worried, looking for information. The parents going to the doctor. It could be the family doctor. And the family doctor doing an extensive examination. The family doctor then referring to the specialist doing an extensive examination, and the specialist then ordering the genetic test. And then finally, the specialist making the diagnosis. So if that's the whole journey, there are actually 3 points where I think the screening tool could work very nicely. The first one for me is the most attractive one, which is the parent. The parent being worried, the parent looking on the internet, for instance, going to websites to figure out what's going on. Is this normal? What am I seeing? My child is not yet sitting. Is that normal at this age? So that could be the moment where a screening tool could be used. But also at the primary care doctor knowing that there's a screening tool out there and saying to the parent, hey, check out this screening tool, have a look at it, and let me know, share with me what the outcome is. The same goes for the specialist. The specialist could use such a tool as well. But in each case, the parent or the patient could be using that screening tool directly rather than overburdening the healthcare system. When we create those screening tools, they need to be compelling. You know, having a screening tool for only one syndrome is not really that interesting for a parent or for a doctor or a specialist. So when you create a screening tool, ideally you would want to have something that actually covers a whole range of disorders with the signs and symptoms that the parent are concerned about. So it really should not only cover rare diseases for the infants, and there's many rare diseases, but also the more common diseases of the infants as well. So this is not so easy to establish, but I'm just giving you, like, in an ideal situation, that's what the screening tool should do. And it should really target the people benefiting most. So if you think about 140 million babies born every year around the world, screening all those 140 million babies is hugely inefficient. So we really would need to screen those where the parents are seeing there's something not quite right, or they are worried about something not by being quite right. And so we would then need to link up such a screening tool with, for instance, website where parents go, or we would need to have very efficient digital marketing campaigns such as Google search engine targeting, so that that people who are searching, the parents are searching on Google, that they get directed to the right website with a screening tool. The last, but also super important thing, which should never be overlooked, is it's all very well for parents or for patients or for subjects in the general population to be using screening tools. But at the end of the day, the information needs to be shared with the healthcare professional, because the healthcare professional can make the diagnosis. So it would not be right for a screening tool to tell the parent your baby could have this and that disease. It's not ethical. But what we would need to do is to make sure that the parent has the ability to use a screening tool, and that the results of the screening tool, the data coming from the screening tool, is shared with the healthcare provider, so that it helps the treating physician, therefore, to make that diagnosis. Again, my views, maybe a little bit new, but that's my opinion. So thank you very much for giving me this time, and I'm very happy to take on any questions.